Good morning, everyone. Can you see our video on your side? That's it. Okay, good. Good morning, everyone, and welcome to today's webinar. We have two exciting speakers today. The first speaker is Dr. Siyasanga Yekani. Siyasanga is a urology registrar at Groote Hospital. And Dr. Yekani will be speaking on perioperative thromboprophylaxis, which is an important and very practical topic that we encounter regularly across our elective and emergency surgical practice. As our surgical patients become increasingly complex, balancing the risk of thrombosis and bleeding remains an imperative part of our perioperative management and decision making. So, Dr. Yekani, thank you for taking us through this topic. You can start your talk.
Good morning, everyone. So as Aman said, I'll be presenting on perioperative thromboprophylaxis in urology. And then this is my list of contents. I hope it's not as long as it looks, but I'll basically just be covering why this matters to us, a bit of biology, some definitions. I'm largely using the EAU guidelines for this whole talk. So it will be based basically on that. So we know that urology basically sits at the intersection just between thrombosis and bleeding risk. We have cancer, which increases just on its own the VTE risk, and then the surgeries that are related to the cancer itself, which involve a lot of manipulation. We have our pelvic venous plexus, which all contribute to bleeding risk. So as I said, I am using the guideline as it is centered around balancing these competing harms. So VTE essentially encompasses DVT and PE, and the stats show that about 10 to 30% of urology patients develop DVT without prophylaxis, and major urological procedures carry around 1 to 10% chance of a risk of fatal PE, and it is known as one of the most common and preventable causes of perioperative death. And then in terms of oncological pelvic surgery, especially our open radical cystectomy, carries the highest risk in this regard. And these events are significant, and what's interesting about them is that a large number of them actually occur post-discharge. And then we have bleeding on the other end, which is an equal threat as important as VTE. And we know that our kidney, prostate, bladders are highly vascular, and basically hematuria is inevitable in these cases. And hematoma, transfusion, and reintervention all prolong our patients' length of stay and basically compromise recovery. So in terms of how prophylaxis works, it reduces VTE by 50%, but it also increases bleeding by 50%. So the net benefit basically will then lie in the patient's risk profile. So if a patient has a high VTE risk, but a low bleeding risk, then we know that prophylaxis is basically has a net beneficial effect in these patients. However, on the other end, if the patient has a low VTE risk, but a high bleeding risk, then in this case, prophylaxis may actually cause more harm than benefit. And then just background biology of bleeding and clotting. I'm not going to go into that whole clotting cascade. I'm sure we all don't even remember it from med school. But in summary, you have your primary hemostasis and secondary hemostasis. In the primary, this is where you get endothelial damage from whatever procedure that you're doing, which then leads to adherence of platelets. These get activated, they aggregate at the site of the injury, and then they form an initial platelet plug. And then your secondary hemostasis that has your extrinsic and intrinsic and common pathways. Basically, it generates thrombin, which converts fibrinogen into fibrin, and this stabilizes that clot that was formed into a more durable clot. and our bodies naturally have anticoagulant defenses, which exist. First one being antithrombin 3, we have protein C and S, we have the tissue factor pathway, and fibrinolysis. And the important thing here is that surgery actually disrupts this whole hemostatic balance. There's upregulation of your tissue factor, platelet activation is increased, stasis, there's decreased anticoagulant proteins. Cancer itself also amplifies clotting by increasing your tumor-derived tissue factor and procoagulant microparticles. So this risk is basically with cancer patients, especially seen in the first 30 days of the post-operative period. Okay, so then we have our drugs, basically that act on this pathway, and they target the specific pathway. So we know that we need to know this because obviously we need to know what we are giving and why we're giving it. We have our low molecular weight heparins or unfractionated heparins, which act on antithrombin. We have our direct oral anticoagulants, which basically directly act on factor 10A, warfarin, which inhibits our vitamin K dependent factors, and then aspirin, which inhibits COX-1 and leads to decreased platelet aggregation. And we all know Virchow's triad. Rudolf Virchow identified these three conditions that basically predispose to thrombosis back in 1856. And essentially, all three elements are amplified in uro-oncology, in oncological urology, whether it's the pathology itself or the operations as well. So patients with cancer, we know, have about a 3 to 6 times risk of VTE compared to patients that don't actually have cancer. And as I've alluded to this before, surgery disrupts all these three factors, whether it's the actual operation or the way we position our patients, such as, okay, if we start with stasis, if we look at how we position our patients, especially for our robotic ops, so the venous stasis is quite significant there. We use pneumoperitoneum. We have very long operations, especially our open radical cystectomies or robotic radical prostatectomies. Post-operatively, our patients are immobile and they have to sometimes be on bed rest. In terms of endothelial injury, extensive node dissection, radical cystectomy with dissection around the vessels. And we know that open is this is more pronounced in open surgery more than laparoscopic and more than a robotic surgery. And our diathermies, traction, and a port insertion also leads to endothelial injury. In terms of hypercoagulability, as I said, the cancer itself can cause a procoagulant state, and bowel prep can dehydrate the patients and lead to hemoconcentration, and then this actual surgical stress as well, which increases our platelet aggregation. And then our types of thromboprophylaxis, we get 2 types, pharmacological and mechanical modalities. Low molecular, we have our indirect thrombin inhibitors, which include our heparins and then fondaparinux, and then our direct oral anticoagulants, such as rivaroxaban. The advantage of these are they oral, they're quite predictable in terms of dosing. They potentially lower cost and quite preferred by patients. And then we have our vitamin K antagonists, such as warfarin. And then lastly, our antiplatelet therapy, which includes our COX inhibitors, such as aspirin, ADP inhibitors, such as clopidogrel. And obviously, this pharmacological and mechanical means work differently in terms of mechanism, the evidence, and practical application. And then looking just at the contraindications for thromboprophylaxis. This include active major bleeding, coagulopathy, thrombocytopenia, heparin-induced thrombocytopenia, renal failure, and then within neuroaxial holes. And then in terms of just looking at a direct comparison between our direct orals and low molecular weight heparins, we have two systematic reviews that basically essentially showed that none is inferior. So your direct oral anticoagulants are comparable to low molecular weight heparin for VTE prevention, with no significance basically in bleeding rates. And then the first study actually showed that basically it was directed more to urological patients and showed a reduction in VTE, specifically with DOACs in urological cancer surgeries in terms of decreasing VTE. But they essentially are comparable if we look at VTE risk. And then moving on to thromboprophylaxis, we have two types. We have our intermittent pneumatic compression, which is the preferred type, and then our graduated compression stockings, which are basically seen as an adjunct. They have a very limited standalone role in urology. And then just the key points from the EAU, they graded 2C, basically need to be used alongside pharmacological modalities for higher risk procedures. And you use them as monotherapy or alone when pharmacological therapy is contraindicated. And they are contraindicated in patients with ankle brachial indices of less than 0.5. If a patient has an active DVT and in severe edema. So like I said, I'm basically just looking at the guideline because it makes sense in terms of how they came up with the recommendations and why we should do what we are doing. So I'm largely using that as a guide for this talk. So they focused basically on clinically meaningful events and not just looking at otherwise asymptomatic findings on imaging. So in that way, they basically they weighed the reductions in VTE against an increase in major bleeding. Like I said, you get that bleeding, you get VTE equally. So they started by just defining what they mean by DVT, what they mean by PE and major bleed. So just briefly, DVT they define it as a thrombus in the deep vein that is identified on duplex ultrasound or venography. And it's in those areas that I mentioned. And then they use this symptomatic DVT as a primary outcome in most of the RCTs that they looked at. And then PE is confirmed on CTPA or VQ scan. And then fatal PE is obviously death that ensues from PE, where PE is the primary cause, and then non-fatal is in a hemodynamically stable patient, and they note PE as the most clinically significant VTE event. And then with major bleed, it's bleeding that requires reoperation or reintervention, such as selective angioembolization. It does not include transfusions or indwelling catheters or a change in hemoglobin. And then the three landmark trials that are cited in the guideline as well, that basically provided the evidence base for when VT prophylaxis should start and how long it should continue for. And I'll be citing some data from these trials in the subsequent slides. So in terms of the timing of post-operative events, So anticoagulation, they didn't just decide arbitrarily when to start and when to stop. It was actually derived from studies that mapped out exactly when post-operative events are more concentrated, or when they are worse, or when they actually start being relevant. So this was the foundation of the current dosing regimen. And in this graph here, we see that, bleeding starts basically, or it peaks in the first 12 to 24 hours of surgery. You get your wound and anastomotic bleeding, which is basically immediate in the perioperative window. Hematuria peaks in the first 24 hours, and then it rapidly declines. And then the risk of bleeding is said to then substantially diminish by 48 to 72 hours post-op. So the graph basically does show that it peaks and then it tapers down. Um, and then moving on to VTE. So VTE basically it does the opposite. It doesn't peak in the early days. And is said to peak in post-operative days 7 to 14 in most of the procedures. And then there's an extended risk period that exists beyond that, so 48 weeks in major cancer surgery. And then with radical cystectomy, it's actually been noted that these events may even occur as late as 90 days post-op. And this graph again shows the different relationship between bleeding risk and VTE events. And like I said, this was basically the foundation of deciding when to start medication and when you would have to extend medication or prophylaxis in higher risk patients, such as the radical cystectomy patients. And then that 50-50 problem that I spoke about in the beginning, where prophylaxis essentially gives you protects you, gives a 50% protection against VTE, but then subjects an individual to a risk of 50% in terms of bleeding. So there's several meta-analyses that have come across in urology, in general surgery, gynae, that have informed this guideline. So instead of us thinking, or them thinking of outcomes in isolation, they basically looked at them in terms of net benefit, which is something that came across in most surgical disciplines. This is a study by Collins, so I've included two, Collins and Miss Meti. The first one, Collins et al. From 1998, basically gave us the largest pooled analysis that looked at perioperative anticoagulation. The study was in 1988, so quite a long time ago, but it was quite an impactful study. Consisted of about 16,000 patients across general surgery, orthopedics, and urology. And then what they demonstrated was that a peri-op subcutaneous heparin significantly reduced fatal PE and total mortality in surgical patients. And then how the study basically was relevant is because it essentially established the fundamental effect sizes, the 50-50, and the subsequent guidelines were then built on the study. And then there hasn't really been another modern study after this that has been able to compare to this, because really getting fatal PE is now sort of rare. So it was more powered back then without the prophylaxis. So it's sort of studies now built on that. So so essentially what I just said is not a universally beneficial thing. It depends on the patient's VTE risk and the baseline bleeding risk. So this is what we have to look at, obviously, and I'll expand on this in the following slides. And then this Ms. Meti study in 2001, basically looking at low molecular weight heparin in prevention of thromboembolism in surgical patients, also included urological patients here. And it's now become the standard low molecular killer weight heparin, which is what we also use. It's become the standard of VTE prophylaxis in surgical and in medical patients. And it has the same efficacy and a better safety profile and better practicality compared to unfractionated heparin, which was previously used before. And then, yeah, so this is again just repeating that 50-50 concept that what this whole graph and well, there's two graphs put together show it basically that there's a 50% reduction in fatal PE, and this is the most important benefit, and what EAU then termed a very hard outcome. And then it also shows that there's a 50% increase in wound hematoma, which is also a significant surgical complication. And then we'll speak about net benefit and how they calculated that, but this is basically what we use to strengthen our recommendations. So before recommending, obviously, the EAU then identified 5 principles that they basically used and considered that will strengthen their recommendations in order to create a more robust guideline. And I'll just briefly go into those. The first one, looking at relative effect of prophylaxis on key outcomes. So we know our key outcomes are bleeding or VTE. So they weigh the critical hard outcomes, which are your fatal PE, fatal bleeding, above surrogate. So a surrogate would be an asymptomatic DVT. And the surrogates are basically don't justify giving prophylaxis if a patient's bleeding risk is high. So you essentially be subjecting a patient to the risk of bleeding with an otherwise not hard outcome. So in terms of mechanical and pharmacological prophylaxis, they showed 50%, both showed 50% reduction in VTE. And in terms of pharmacological specifically, they had high quality evidence for that, with mechanical prophylaxis having lower quality evidence. And it was an issue of uncertainty, and the studies were basically underpowered, and they had more surrogates than pharmacological. So the evidence with the mechanical prophylaxis wasn't quite as convincing as pharmacological. And then just looking at our mechanical prophylaxis, we have 3 key trials that basically had compared how mechanical prophylaxis works alone with no pharmacological prophylaxis, and then they looked at how they work when they are in combination. So most of these studies are in general surgery, in orthopedics, or in neurosurgery. And then in our urological specialty, the studies are they're not as robust. They are of low certainty, and they use surrogate outcomes. But in any case, what the data shows is that combining your mechanical prophylaxis with pharmacological prophylaxis has a definite additive effect. And like I said, this data is extrapolated from other specialities, not specifically our own, but there is definitely a proven additive and beneficial effect in adding mechanical prophylaxis to pharmacological. So as I said before, we have 2 types, your TEDs and your IPC. And essentially, you will look at how you're going to use this. If you're going to use it alone, it is because low molecular weight heparin is usually contraindicated. And this is usually during that period where there's a higher risk of bleeding. So you can use IPC alone in that regard. Where you cannot use, and then where it's recommended to use a combination is in patients such as patients for radical cystectomy or who are at very high risk. So combination of these is strongly recommended by the EAU. And then, oh, sorry. And then in terms of the third principle, they looked at patient-related risk factors. And these are things that can amplify your VTE risk or your bleeding risk. And they basically used these to then add on to the guideline and the algorithm that I will go into at a later stage. But it's essential to look not only at the surgery itself, it's important to also take into consideration other factors, patient factors that may contribute to bleeding or to VTE risk. I don't know, some of my graphs have disappeared from this computer. I apologize for that. But yeah, anyway, the other way that the VTE risk can be quantified is by using the Caprini score. It's mostly used, I think it was used mostly in medical, it originally developed for surgical patients, but is now generally being used by surgeons, and it's used by the medical specialities as well. And then in terms of risk stratification, so the EAU then extrapolated from high quality studies, like I said, and they came up with their own risk model, which has 4 factors. These should then be combined, like I said, with procedure risk to then determine the final decision. So their model is not validated yet, and clinicians are basically encouraged to consider other important factors such as your length of stay. If patient has, for instance, spinal cord injury, they're immobile, they're on contraception, all the other factors I've listed before making treatment decisions. So not to just look at this model, but anyway, they then divide the patients into low, medium, and high risk. Low risk patients are patients that are otherwise less than 60, no personal family history of VTE, and are not obese. Medium risk is anyone that has any of the factors. And then high risk patients are patients that have 2 or more or have a personal history of VTE. So this is a model for VTE specifically. There is no model for bleeding from the EAU because they said they couldn't find any convincing or replicable risk factors in the studies that they looked at. So this only looks at your VTE risk. And then the fourth principle is they basically looked at the quality of evidence before they graded well, they used that as a grading of their recommendations. And how they looked at this is they basically calculated the net benefit of what the prophylaxis would do, looking at your absolute reduction in your VTE risk minus the absolute increase in your bleeding risk. So if it's a clearly positive effect, then they gave a strong recommendation for that. When it's a clearly negative one, they gave a strong recommendation against that. And if they were uncertain, they basically then just said it's a weak recommendation based on that, the fact that they had some uncertainties, whether it was the quality of the data or other factors. Okay, and then this was actually a very important picture, but also didn't show. This is the last principle that looks at a relative importance of relative outcomes. So it basically shows each procedure and it grades it according to what risk it carries in terms of VTE. So looking at your TURBTs compared to your cystectomies, nephrectomy, and it grades that according to, it gives a percentage to what type of risk the certain procedure carries. And why they did this was basically to highlight, for example, if a patient is having a TURBT, the risk of VT is about 2%. And in the beginning, remember I said you would subject that patient to a 50% chance of bleeding. So you have to sort of look if prophylaxis in that case makes any sense in view of the fact that the VTE risk is only 2%, but you're subjecting the patient to a 50% chance of bleeding, as opposed to a radical cystectomy where it carries a higher risk of VTE. In that sense, then it makes a lot of sense for you to give prophylaxis, because the risk of bleeding is sort of the same as the risk of forming a clot. So it's not just merely prescribing prophylaxis to everyone as an umbrella thing. You have to actually individualize and look at the procedure itself and the patient factors as well. And then when we put all of this together in the sort of a decision framework, so you assess the procedure risk itself, the previous picture that was in there, and then assess the patient's VTE risk. You can use the EAU guideline for that bleeding risk, and then choosing which agent and when to start, and then you can determine the duration of that. And then this is basically an easier way of thinking of this. So your step one is to look at your procedure. If it's an ambulatory day surgery case, then there's no prophylaxis that is needed for that case. Major open oncological, those ones you definitely, like a radical cystectomy, you definitely need pharmacological and you need mechanical, which is suggested in those cases. And then all the other procedures you stratify, looking at the patient's risk factors and looking at the procedure itself. And then step two, the net benefit, you see if it's going to benefit the patient, what is the risk of the procedure, what is the patient's risk as well. The timing or the recommendation is to start on post-op day one. And then for patients that are high risk oncological patients, you extend this by 4 weeks. But you only stop if the patient actively bleeds. So these are the quick reference guides on the right, and just in the interest of time, I'm not going to go into that, but they are in the guideline. And then briefly on perioperative management of patients that are already on chronic antithrombotics. So we always get confused about bridging, and we bring patients in for bridging when there's actually sometimes no need at all to do it. And the baseline thing here with bridging is you only do it when the risk of stopping is high. So patients that have mechanical heart valves, if they've had a recent, like in the last 3 months VTE, or if they have AF with a prior stroke or a TIA. So we shouldn't be doing it routinely. And this was actually proven in one of the trials called the Bridge trial. And it highlighted how we actually expose patients to an increased risk of bleeding by doing this bridging when it's actually not needed for all the other patients. And then intermediate and low risk, intermediate, you'd have to decide case by case, and then low risk, you don't need to bridge at all. And then I know it's a busy slide, but I'll just highlight the most important things here. With your antiplatelet therapy, you stop 7 days before and then start 4 days after. But in the high-risk patients, you actually, if you can, they say if you can postpone the surgery, rather do that. Delay the surgery if the patient is on antiplatelet therapy. But if you have to go through the surgery, if it's an emergency, then you can carry on with the antiplatelet therapy and with the operation as well. So do them simultaneously. And then with the patients that need special attention is obviously your renal impairment patients and obese patients, where you would need to renally adjust your drugs, or you would have to basically use alternate drugs. And then with the recent or active VTE, the recommendation is to delay elective surgery, and then ideally by 1 to 3 months, unless it is an urgent operation. In that case, you would have to, then they recommend an IVC filter, which won't basically replace the thromboprophylaxis. You'll institute that either way post-op. And sorry, when I have to move on. I wanted to talk about that, but I think because the EAU also really doesn't have much information on tranexamic acid as yet, they do acknowledge it, but there's no formal recommendation that has been made in terms of prevention of bleeding. And there is, at this stage, insufficient urology-specific evidence to assign any grade regarding tranexamic acid. Okay, so this is just a summary, and yeah, that concludes my talk.
Thank you, Siyasanga, for such an informative talk. Do you have any questions on the floor before we continue? Yeah, question from Prof.
Thank you, Sir. I'm embarrassed to admit I learned a lot from that talk. One question came to mind was, we looked at the oral agents are equally effective in the two trials that you presented. Why are we not using that? Because I hear even in the developed rich world, if we can use those terms, they still prefer taxane for these kind of cases.
So apparently surgeons are quite skeptical. So people aren't really ready to adapt new guidelines in terms of thromboprophylaxis. It's apparently a universal thing where we don't know much about thromboprophylaxis and we tend to just stick to what we know or what our institutions have been doing for a long time. So what I thought was the reason because of that, because the evidence clearly shows that we can use all these things, but no one we talked about it was we never really talked about thromboprophylaxis, and we just sort of continue with what we've been doing over the years.
The cost of the orals versus, we were just chatting about the cost of the oral versus the.
Oh, I said it's potentially cheaper. I don't know the actual cost. I don't know the actual cost, but potentially cheaper. If it is changed, then shut over that one.
The costs are coming down.
Yeah.
There are multiple variations of it. The Russians only one now.
Yes.
So it's difficult to reverse them. Yeah, and that's a little bit, but then they about that. It's not very long. They're very predictable. So yeah. But I mean, kids say it's still going to be a faster actually, more but I think, yeah, we must demonstrate, especially sending on kids say we should put it in one of the rocks, but it's more and more available. But I think we are to add this motivator as well. So it's been amazing looking over and see where they are. I mean, we shouldn't be having to send our post-op patients on it. I mean, we should.
Thank you. Any other questions on the floor before we continue? Good. Okay, so our second speaker today, we have a special guest this morning, Prof. Lydia Cairncross. Prof. Cairncross is the head of Department of Surgery at Groote Hospital at the University of Cape Town and works within the endocrine surgery department. She's a highly respected academic surgeon and educator with extensive experience in endocrine pathology and surgery, and has played a major role in surgical leadership, training, and academic development, both within our institution and nationally. So adrenal incidentalomas are being identified more frequently in modern practice, often presenting a challenge between reassurance of appropriate investigations or doing extensive endocrine workup and deciding whether surgical intervention is actually necessary or not. So today, Prof. Cairncross is going to take us through the approach to adrenal incidentalomas and their management. Prof. Cairncross, thank you for joining us and we look forward to your talk.
Okay, thanks everyone for the kind introduction. Yeah, let's see if I can do like a next to podium by short. I can do that actually. Okay, morning. So how's everyone doing? Thank you so much for inviting me. Thank you, John. As I said to Aman, it's very similar to the last time. But hopefully there's some new people in the audience, and I certainly can't always remember something that I heard 2 years ago. So here we go. So how does it move? Oh, I have to do it then. Okay, that's fine. Then let me just move this to the side so you can see me. Okay. All right. So, I mean, I'm going to tell you a little bit about, to frame it, why do we remove the adrenal gland? And then we're going to talk about the adrenal incidentaloma. So we take out the adrenal really for two settings. One is when the patient presents via medicine or a physician or general practitioner with very, very high and uncontrolled blood pressure. And then we work up the patient, we find that they've got a hormonal cause for their hypertension, and then we would remove the adrenal gland. So that's not what we're talking about today. Here we're talking about the other side, which is patient presents with a mass in the adrenal gland, and is this benign, is this malignant, when should you remove it? And that is the adrenal incidentaloma. The definition of an incidentaloma is it's an adrenal mass more than 1 centimeter, which is essentially found in the adrenal during investigation for something completely unrelated. So it's specifically not when you're working up a patient for Cushing's or a patient for a FEO that's got the hypertension, because there it's not incidental, it's part of the workup. It's also not when you're working up a patient with one of those strange hereditary syndromes or a patient with cancer. So if a patient has a malignancy, we find an adrenal mass, it's not an adrenal incidentaloma, that is this a metastasis? So it's just those patients who are having a CT scan for diverticulitis or maybe a renal stone or something like that, and you pick up a mass in the adrenal gland. So is it common? Yes, it's really common. I'm sure do you come across this in your clinics fairly often? Okay, so autopsy studies, 2% of the population has got a mass in the adrenal gland. It's a little bit like the thyroid. So we deal with sarcomas, thyroids, and adrenals in my line of work, and there are lots of thyroid nodules. Similarly, in the adrenal, we pick it up quite often. And the more you scan patients, the more you're going to see adrenal incidentalomas, because it increases with age, and the more you imaging, the more you pick up. So in young patients under 50, probably only 2% of your scans will have an adrenal lesion. But at 70, and this is kind of the urology population age as well, about 10% of the scans could have an adrenal mass. So that's a massive diagnostic problem to deal with. Before we go into how to manage these, it's helpful to know what could this be. So there's a lump in the adrenal gland. What could it be? Most of them are benign, and that's kind of the main message of this talk. So 90 to 95% of incidental lesions in the adrenal are benign. And what are those benign lesions? Many of them are non-functional adenomas, so it's just a growth in the adrenal gland. Then you have the hormone-secreting adenomas, that's cortisol secreting, Cushing's, pheochromocytoma, adrenaline secreting, and aldosterone secreting, which is con. So those are the three things that kind of we spend our time doing in endocrine surgery and taking them out. And then this is kind of the part that you're worried about, which ones are malignant. So probably around 5% of them, I actually think probably less than that, but it's hard to work that out because we don't take them all out. But probably around 5% of them that you're worried about and are investigating turn out to be malignant. But the problem is, when they are malignant, they are very, very aggressive malignancies. So an adrenocortical carcinoma is not something you want to miss, because they grow rapidly and they're hard to treat. So that's the differential diagnosis. So how are we going to tease out this common, mainly benign pathology from the occasional aggressive malignancy that we do see? Okay, so just to remind you, the adrenal gland has got those 3 zones, and they produce different hormones. From the surgical perspective, the hormones we really are concerned about are aldosterone, cortisol, and adrenaline, which are the hormones that produce the 3 main pathologies in the adrenal gland. And those are the ones you need to know how to investigate for. So pheochromocytoma, I'm sure many of you are sending urine metanephrines already for pheos to check for them. So urine metanephrine needs to go in a special acidified bottle. Yes, you've been down this painful path of like you can't find the bottle, it's the wrong bottle, they send it back. And then it goes to the laboratory after you collect the urine for 24 hours. Our problem is it then takes a very long time to get the result, which is actually getting worse. I think the timelines are getting worse because it goes to a laboratory, either Red Cross or now KZN. You can do plasma metanephrine, so we don't have it available at Groote. But plasma metanephrines are very sensitive, but not very specific. So they're not very accurate. So if you want to screen, you could do a plasma. We don't have it. So that's the fear. Cortisol secretion, you measure by doing an overnight dexamethasone suppression test or a 24-hour urine test. Anyone done a dexamethasone suppression test or asked for one? Not really. The cortisol secretion, you could talk for an hour about how to test for it. We don't really need to know that. What we need to know is, how do you screen for high cortisol? And the way we screen in this hospital mostly is with a urine cortisol as well. So the patient does a 24-hour urine collection for metanephrines and then a 24-hour collection for cortisol. The overnight screening with dexamethasone is quite useful because the patient could go home potentially. So there you give them 1 milligram of dexamethasone at 11 o'clock at night, and you do a serum cortisol at 8 in the morning. And it's actually a much simpler way to test for hypercortisolism. After you've made the diagnosis, you should refer it to an endocrinologist, and they can do the other suppression tests and everything else that needs to confirm the diagnosis. But those are probably the two you're most likely going to engage with. The third test for function is aldosterone, and this is to look for Conn syndrome. And here you do a serum aldosterone and renin level, and you will know this well from the kidney, but they should be in a ratio that's reasonable. So as renin goes up, aldosterone goes up. But when your tumors is secreting aldosterone, you have a very high aldosterone level and a suppressed renin level. So it's the difference between your aldosterone and renin that gives you the diagnosis. Again, you're going to send off the blood test and you will ask an endocrinology colleague to help you interpret it, because every laboratory has a different range. What we need to know is aldosterone is usually over 1,000 if you are dealing with cons, and your renin is very, very low. That's kind of conceptually where we are. Sex hormones, we only test DHEAS if we're really concerned that this is a malignancy. Otherwise, you don't need to test it. And I think that's important to know because we over-investigate these patients. So if you have a CT scan and you pick up a mass in the adrenal, you're essentially asking two questions. Is this tumor producing hormones that are abnormal, which we've just been down through? So to test for hormones, you would test for catecholamines, so metanephrines, you would test for cortisol, and you would test for aldosterone. We, in practice, don't always do the aldosterone test, and we don't do the DHEAS unless the patient is hypertensive or you're worried about virilizing symptoms in the patient. So most of the time, if you're screening the patient, you must always do the metanephrines because that could kill the patient. And you should probably do the cortisol because you can treat that. Cortisol patients with Cushing syndrome, you can see that they have Cushing syndrome. So if you've got a rake-thin 35-year-old with no hypertension and they've got a mass in the adrenal, make sure you do the metanephrines. The other things are at your discretion. Definitely the aldosterone is only if the patient is hypertensive. Patients with Conn syndrome in our setting present with profound hypokalemia, low potassium, and severe hypertension, so they are symptomatic. We're always making these decisions about how we manage and investigate patients. So for me, always do the metanephrines, mostly do the cortisol, and only do the aldosterone if it's indicated. So that's decide if it's functional. If it's a functional tumor, you're going to send the patient to us and we will do an adrenalectomy. What about you've done a CT scan for renal stones and you pick up something in the adrenal, you've done the functional workup, it's negative. The next question is it malignant or not? Because you need to make a decision, am I going to discharge the patient, follow up the patient, or do an operation? So the rest of what I'm going to talk about is trying to distinguish the benign from the malignant on the basis of the CT scan. Okay. So there are lots of guidelines, and this is the one that I think is most useful, the European Society of Clinical Practice. They'll probably do an update now because it's about 10 years ago. Okay, so are we all on the same page, right? We've got a CT scan, we found the mass, a friendly physician has already done the endocrine workup, so the patient has negative endocrine workup, it's non-functional. Now it's like, is this a cancer? So the data on this is a little bit old, but it still holds. There is a size component. So the smaller the lesion is, the less likely it is to be malignant. And the bigger it is, the more likely it is to be malignant. And the cutoff is probably around 6 centimeters. If you're looking at something that's less than 4 centimeters, the risk of cancer is quite low. If it's more than 6 centimeters, it's about 25%, and in between is a gray zone. Now, people always say to me, but I mean, a tumor starts small and then it grows, right? But this is it's around probabilities. So 2%, the adrenocortical carcinomas grow so quickly, it's quite unusual to find a very small one. Lucky for the patient, but it's quite unusual. So size is one component in assessing malignant risk. The next component we look at is what exactly is this mass made up of? What is it constituted of? And most of the benign lesions are lipid-rich adenomas. In other words, it's fatty tissue. And on a CT scan, we pick up fatty tissue by looking at the Hounsfield units. So if you have a solid, malignant, highly vascular mass, it's going to be dense on the CT scan. And therefore, it's going to have very high Hounsfield units. We're all on the same page. HUs, you've read them on the CT scan. If your Hounsfield units on your uncontrasted scan is very low, less than 10, it is a very, very, very good negative predictive test for a malignancy in the adrenal gland. So, I mean, many of the studies say it's close to 100%, so 98, 99%. And this is the value of the uncontrasted scan. So if you have a contrasted scan, you can't interpret the HU. You have to have an uncontrasted scan. But if you have an uncontrasted scan and the HU is less than 10, you can feel quite confident this is a lipid-rich fatty adenoma. If the patient is non-functional, that's good news. If, in fact, the radiologists are taught that if the uncontrasted scan shows less than 10, you can stop there. You don't have to do the rest of your adrenal protocol. But if the Hounsfield unit's more than 10, you should continue and do your washout. So you've heard of this, the triple contrasted scan for the adrenal protocol. And the adrenal protocol washout shows, I think that might be mine, just do like something on it. Don't answer, it's okay, I'm sure. So washout is how much contrast is held by the tumor and how much of it washes out over a period of time. It's quite difficult. I often struggle to remember which washout is good and which washout is bad. Essentially, if your washout is high, it's good, and if your washout is low, it's bad. And the way I think about that is that nasty tumors hold on to the contrast, they don't let it out. Whereas the more benign ones allow the contrast through and you get a high washout. It's not a very scientific way to remember, but that's the way I remember it. So high washout is good and low washout is bad, and that helps you to make the decision. We really do the first two. These other three can be done. It's not part of our standard practice. You can look at MRI, you can do FDG PET, and you can do an SUV at adrenal liver ratio. So these things are not something that are really available to us routinely, and we very seldom do them. But the first two, we definitely do. Okay. Maybe before we go, okay, let's stay there. So we've just got the CT scan, and we've gotten a special uncontrasted scan. If the uncontrasted scan shows more than 10 Hounsfield units, we proceed to do a triple scan to look for washout. And now we've got size, Hounsfield units, and washout as our information. If we're still not sure, why can't we do a biopsy of the lesion? And there's quite a lot of discussion about the role of FNA in assessing an adrenal lesion. First of all, it's not that easy to do. So you need to have a confident conventional radiologist, which we do now, because they will put a needle into anything. And then it's not always adequate. So like any FNA, you don't always get a good answer. And when it's an incidentaloma, your sensitivity is really quite low. So if you get, this is probably benign, you're not really further down the path about what to do for the patient. If it comes back as malignant, then you've got a very high specificity. So we usually only do FNA when we're worried about a metastasis. So a patient has a colorectal cancer and they've got a mass in the adrenal. It's valuable doing an FNA because it will tell you this patient now has stage 4 colorectal cancer, and it shifts your management protocol. If you have an adrenal mass, You do a biopsy, it comes back benign cells. You know that the sensitivity is quite low, and it doesn't necessarily tell you whether or not to operate on the patient. So we don't do FNA routinely outside of the malignant setting. Okay. There are a few special circumstances around the adrenal. So, as I said now, if the adrenal becomes about a malignancy associated, there's a very good yield of biopsy. And the adrenal gland has a very, very high blood supply. So like 25% of the body's blood supply goes through both adrenal, highly vascular organ, as we know when we do adrenal lipomas of myelolipomas of the adrenal, they bleed a lot. So the risk of having a metastasis there is relatively high considering how small the gland is. So that's the first special circumstance. Sometimes you've got adrenal tumors on both sides. Has anyone seen that? So the CT scan shows a mass on both sides. Now what do? Essentially, you assess each mass independently. This one, how big is it? What's the HU? What's the washout? This one, how big it is, etc. And of course, you do a functional workup. Patients under 40. So the theme of my talk is don't panic about the adrenal tumor. But in under 40-year-olds, if you remember to the first slide, it's much less common to have adrenal incidentalomas in the young population. So a young patient with an adrenal mass is much more likely to have a functional tumor or some kind of malignant tumor than an older patient. So I'd be a little bit more concerned about young patients. The opposite for elderly patients. In elderly patients, you want to hold back on operating unless you really need to. And then myelolipomas, which, I mean, I've had the recent experience, I didn't know that you can get them coming from the kidney as well. So either from the adrenal gland or from the kidney. And myelolipomas can be really big and they're still benign. So we often have a debate, should we take this out? It's 7 centimeters. It's a myelolipoma. It's not a risk to the patient. And so that's a special circumstance as well. Okay. So I'm not going to go through, I'll come back to that slide. There's a little bit of controversy around some of the management guidelines. So if it's less than 4 centimeters, you don't have to worry. If it's more than 6 centimeters, you do have to worry. But like what happens between 4 and 6 centimeters? You have to individualize and think it through. And then you have patients, this is not necessarily relevant to surgery, but you have patients who have a little bit of cortisol secretion. It's higher than normal, but not enough to diagnose Cushing's. And the question is, should you remove that adrenal gland or not? But this is kind of really where, and this is an algorithm that I've drawn up with medical endocrine, and I think it helps us a lot. So I want to start on this side. So it's adrenal incidentaloma. Remember, there are 2 big questions. Is it functional? Is it benign or malignant? So on the functional side, you're going to do your 3 tests, cortisol, adrenaline, and aldosterone. If it's non-functional, you're in the green box at the end. If it is functional, you're going to operate on the patient. So the red box is for operating. If it's that minimal cortisol secretion, you're going to speak to Joel Dave and ask him what to do from endocrine. And he will advise whether or not we need to operate. But essentially, anyone with a functional tumor needs an operation. And then on this side, the patient, you pick up an adrenal incidentaloma on CT scan for something else. Do you ever do uncontrasted scans in urology, or do you normally do contrasted? For stones, okay. So you're lucky if you've got an uncontrasted scan, but most of the time, in my experience, we have a contrasted scan. So there's a portovenous and there's an arterial phase, which means you can't assess the Hounsfield units. And this is the practical problem with adrenal tumors. So in that case, you have to order another CT scan, right, in order to look at the Hounsfield units to get an uncontrasted scan. And in practice, you've just seen the patient. The next CT scan is 3, 4, 5, 6 months' time. What's the wait now when you're booking registrars? 3 months. So how urgently do you get the scan to assess the adrenal? I would say if the patient is under 50, you're going to chase the scan. Try and get it done quite quickly. If the patient's over 50, you just book the next scan in the outpatient department, obviously looking at the size of the tumor as well. But you need to have the uncontrasted scan to make the next diagnostic decision. If the uncontrasted scan shows low HU, this is a lipid-rich adenoma. And if it's less than 4 centimeters, you can discharge the patient. So HU under 10, less than 4 centimeters, the patient can go home. Don't have to follow up. If the Hounsfield unit is more than 10, or the tumor is 4 to 6 centimeters, this is a gray zone. Here you can either do another fancy radiology test, or in practice, what we do is a follow-up CT scan in 6 months, and then another one in a year, and then another one a year after that. And then we stop. No one tells you what the protocol is around when to stop. But if in 3 years' time a tumor hasn't increased in size, it's not an adrenocortical carcinoma. They grow rapidly. And then if the patient has high Hounsfield, low washout, it looks nasty, it's big, you're going to do an operation, which is diagnostic. And that's without an FNA. So that's just based on the CT scan. So this is kind of what's coming through in the guidelines. And is that a safe approach? Where's the one I had? There's some really big studies that shows that this is a safe approach. So once the tumor is found to be non-functional, they don't later on become functional. So an adrenal adenoma, which is lipid-rich and doesn't have high catecholamines, is not in 5 years' time suddenly going to become a FEO. So you can be quite confident if your hormone levels are normal, you don't need to worry about that in terms of follow-up. If you have a tumor that's under 4 centimeters and Hounsfield is very low, but almost 100% negative predictive value that it's not malignant. If the tumor is in that gray zone, you need to do your 6 to 12 month follow-up. And if you have a more than 20% increase in size, you may want to consider surgery. So you can see it will be a little bit individualized. And then if you're not sure about the endocrine workup, you may need to repeat it at a later stage, but I would refer to an endocrinologist to take that forward for you and follow up the patient. They will do 10 other tests. They won't only do the ones that have been requested already. Okay, thank you.
Thank you very much, Prof, for excellent talk, and thank you for taking the time to be here with us this morning. Some questions from mine with regards, obviously, the 2 questions, functional and is it malignant? And you mentioned, like on this slide here, if it's functional, you're going to offer surgery. If it is functional, do you still have to exclude malignancy prior to surgery? Is there like a lymph node template that's going to change, if it's a functional thing? That's the first question. Second one is with regards to the absolute and the relative washout. I mean, when do you decide? Like, I mean, it's 2 different formulas, similar formulas, but it's different things to, I mean, is there a scenario where you go for one over the other? And the third one is, as urologists, we, removing the kidney is our priority. So preserving the adrenals are nice to have, but we don't often make it a priority. It's getting that kidney out, stopping the bleeding, etc., etc. So do you feel, obviously we're feasible, we try and preserve the adrenal, but just your sort of message to us, do you think we should be making more of an effort to preserve the adrenal going forward? Or?
Great. So on the first one, was the functional versus...
Yeah, and do we need to exclude malignancy in the functional?
No. So if you've made the decision to operate for a functional tumor, you don't need to do anything more in terms of the malignant risk. So let's say you only have a contrasted CT scan and you've got sky-high metanephrines, going to do an operation on the patient. Whether it's benign or malignant doesn't materially change the type of operation that we do. So adrenocortical carcinomas, we don't do a formal standard lymph node basin dissection like you would do with a pelvic tumor. You basically take the tumor out as well as you can. It's in the retroperitoneum. You will take any lymph nodes that happen to be around there. But when you're doing one next week, actually, when you're doing adrenocortical carcinoma, it's a difficult operation and you're taking out whatever you can take out without causing major damage. So you don't have to do anything more. Once you've got an indication for surgery, you're going to operate. Then on the absolute versus relative washout, this is really just dependent on which scan you have first. So if the patient has not had a proper triple layer CT scan for adrenal, then you can't do an absolute washout. You have to do a relative because you're using the portovenous versus the delayed. The absolute washout is when you've got a form of nipple. So it's a radiological difference. You would order an adrenal protocol, CT scan, and the radiologist will probably give you an absolute washout. But there's sometimes where we don't think it's pragmatic to ask for a whole other CT scan and then work on what we have. And then we've only got relative washout, which is not as predictive as absolute washout. To be honest, I wouldn't operate on a patient just because of a washout. So you're looking at multiple factors: the size of the tumor, what it looks like, is it heterogeneous, how vascular is it? And the most useful thing you can get from the CT scan is the uncontrasted patient. So if you're really unsure, that's the thing that you want to get. And when you do that, you're going to get an absolute washout at the same time. Second best is relative washout, which comes from a standard CT scan. Should we preserve the adrenal gland? So we also take a marker trauma. The adrenal goes like, what adrenal gland? Like it's something on top of the kidney in Gerota's fashion. So, you know, we do a lot of surgery to, we do some diagnostic surgery on the adrenal gland. We very seldom do an adrenal or partial adrenalectomy. We normally take up the whole gland on the one side. So, and patients survive well with a single adrenal gland. I think we probably don't look long term at the hormone impact on quality of life because we don't see those patients, they go to medical endocrine. I have heard some anecdotal narratives about it can become difficult around managing cortisol levels and other more subtle endocrine sort of symptoms that patients get if they have a unilateral adrenalectomy. But the standard teaching is that patients can do quite well, like they can with a single thyroid lobe. They can probably do quite well with a single adrenal, and you know sometimes we take out both adrenals for certain like Cushing's, that's pituitary, and they can't operate on the pituitary. So I think like most things, if you can safely preserve the organ, rather preserve it. Because the patient is at high risk of hypohormonal function later on. But if it's going to cause another liter of blood loss in another 2 hours on the table, I don't think you should. It's a bit of a vague answer, but I think you.
Thank you very much. It's a very insightful talk. I'd just like to pick your brain. We recently had a very interesting case at the MDT, and I think you have all of this under wraps until it's presented in a manner that sort of makes you not know what to do now. And the question was a gentleman who was treated with long course chemo RT for rectal CA and then developed a metachronous renal tumor on the left-hand side, mid-pole, but also bilateral adrenal masses. Now, this is one of the scenarios where they didn't do an adrenal protocol, nor did they do a relative washout. So now you're sitting with bilateral bulky, or well, it was enlarged adrenals. I can't remember. Let's maybe put it at 5 centimeters.
Rectal.
Was a rectal, yeah. So the question now is, do you then request a dedicated adrenal protocol, or would you proceed to FNAs? And if you FNA, are you going to FNA bilaterally or unilaterally, and is that enough? Just sort of stump me a bit there.
Yeah. So I would go for the FNA.
Okay.
So this is a patient with 2 malignancies and bilateral adrenal masses, unless they're myelolipomas, are very, I mean, you're leaning more towards metastases here. And they're probably going to be solid lesions in the adrenal. They're probably not lipid rich. I think if you wanted to do the next investigation for the highest yield, for me it would be an FNA. You know, the adrenal protocol CT scan is for the otherwise well patient who comes in with a thing and they do like, what is this thing? And then it might help you to distinguish, do we chase it, do we discharge, follow up, or operate? But in the setting of malignancy, then my next step would have been to ask for an FNA. Which side? I think the biggest, most nasty looking side. So even without an adrenal protocol CT scan, you can see it's irregular, it's vascular, it's solid. They can tell you quite a lot about the mass, even without the formal protocol. So the most worrying looking tumor, I don't think you should necessarily biopsy both, though you could ask the radiologist how they feel about that. But even just the one side, I mean, if it's done well, it's got a very high specificity, and you should have a good yield from a metastatic deposit FNA. You should.
Right, thanks.
Any other questions? Don't think there are any questions in the chat from what I can see. Well,
What did you do?
Biopsy.
Okay. And?
I think it's still, they're going to still do it.
Sure.
Yeah, it's just afterwards and during it will go study with a dedicated nodded maid.
Yeah.
They're quite symmetrical. That's the only thing. It's just not that
Yeah.
clear.
Which one to go?
And I'm just wondering, would you be happy?
Maybe you do both then. I mean, it's not like it's not going to be a true fact. So if the radiology is happy, maybe because you're trying to also move quickly with the patient's treatment. So you want to do something high steel that's less invasive. So maybe biopsying both of them, then if they look the same, would be the way to go. It's being a little bit pragmatic with these things. So I sometimes see patients in clinic, no decision is being made because we're waiting for the triple phase CT scan for a long time. And sometimes you wait so long, they almost have their 6-month follow-up. And then you're like, okay, let's just do the triple phase at 6 months, and we'll get the size, the HU, and so on. The nasty ones, you can see them quite quickly. The tricky thing is a 4 to 5 centimeter, it's probably lipid rich. And also, some of the benign tumors are not lipid rich. So you can get 30% of them that are non-functional and benign, and that also don't have a very low HU. So the fact that it's got a high HU doesn't mean this is a cancer. So I think just to younger patients worry more, chase your CT scan, older patients under 4 centimeters, book your triple phase when you can get it, but they shouldn't bump the queue of everyone else that's waiting for malignancy staging.
Okay, good. Any other questions? Fine, good. Thank you, Prof. Cairncross, for an excellent talk and sharing your expertise with us. We value your input quite a lot. Thank you, everyone, for joining us this week. We are looking forward to next week's webinars. Thank you.